Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the October 2019 edition of PRS Journal Club podcast. I am Lily Mundy, PRS Resident Ambassador from Duke University, and I am joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis, and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. Adeyiza Momoh, Associate Professor of Plastic Surgery and Program Director at the University of Michigan. Thank you so much, Dr. Momoh, for joining us for this PRS Journal Club podcast.
Hi, Lily. Thanks for having me.
The articles that we will discuss can be read for free on prsjournalclub.com, including an archive of all past Journal Club articles. The next article we will be discussing is a simplified cost-utility analysis of inpatient flap monitoring after microsurgical breast reconstruction and implications for hospital length of stay by a multi-institutional group led by senior author Dr. Mark Smith with data coming from the University of Pennsylvania. The authors start the manuscript by discussing our understanding of post-operative day of flap compromise and associated flap salvage rates. As we know, both the highest frequency of flap compromise requiring return to the OR and highest rates of flap salvage on that return to the OR happen earlier in the post-operative course for most patients. Once patients are several days out from flap surgery, both the likelihood that the flap will have a compromise requiring a return to the OR and the likelihood of flap salvage if they do starts to go down substantially. The authors have focused their analysis on microvascular breast reconstruction and referenced that the current average length of stay of microsurgical breast reconstruction in the U.S. is almost 5 days. The aims of the study were to identify flap take-back days, salvage rates by post-operative day, as well as the number of flaps that need to be kept in-house each day to salvage one failing flap and associated cost numbers with the cost to salvage one failing flap and the incremental cost-effective ratios for inpatient flap monitoring. To accomplish these goals, the authors performed a retrospective review of a prospectively maintained database of microvascular breast reconstruction at the University of Pennsylvania. They queried their database for flap take-back day and salvage rates by post-operative day. From January of 2005 to January of 2016, they included 1,813 patients in their database with 2,847 flaps. 97.6% of these patients received abdominal-based free flap reconstruction. They had 42 flaps that went back for suspected vascular compromise, with 2 flaps going back twice for a total flap take-back rate of 2.4% and an overall salvage rate of 52.3%. The authors excluded flap loss after hospital discharge or if they were unable to determine the timing of vascular compromise. In order to perform a cost analysis, the authors calculated quality-adjusted life years associated with flap salvage. Quality-adjusted life years are an attempt to quantify a measurement of the impact of a given intervention on a patient's quality of life. In developed countries, $100,000 per quality-adjusted life year is typically used as an accepted threshold for what is considered a cost-effective intervention. The authors used BreastQ data to determine quality of life gained associated with autologous breast reconstruction from a national survey of women after breast cancer administered via the Army of Women that was published by Atisha et al. This data was then used to generate the quality-adjusted life years for breast reconstruction. They identified 2 additional articles that describe quality-adjusted life years associated with complete flap loss and calculated the difference associated with autologous reconstruction and associated flap loss. The authors described their protocol for monitoring flaps at the University of Pennsylvania, which includes a clinical exam and pencil Doppler of skin paddles by nursing staff. The nurses perform these exams every 1 hour for the first 48 hours, followed by every 4 hours. They then used Kaiser data from 2015 of average daily inpatient hospital expenses in a nonprofit hospital in Pennsylvania to calculate the cost of the hospital stay, which was quoted to be $2,377 per day. The incremental cost-effectiveness ratio was then calculated as total average inpatient care costs divided by the quality-adjusted life years gained from salvage. The percent of all flaps that were taken back were on post-op days 0 to 1 was 56.8%, and these flaps had a salvage rate of 60%. The number of flaps to stay in-house in order to salvage 1 flap during this time period was 121, which is associated with an inpatient cost of $287,617. They calculated an incremental cost-effectiveness ratio of $38,045 for the post-op day 0 to 1 takebacks. The percent of all flaps that were taken back on post-op day 2 was 13.6% with a salvage rate of 83.3%. The number of flaps to stay in-house in order to salvage 1 flap during this time period was 363, which is associated with inpatient costs of $861,900. The incremental cost-effectiveness ratio here was $114,008, just over the targeted $100,000 per quality-adjusted life year, and what the authors suggest the targeted discharge date should be based on their study findings. The percent of all flaps that were taken back on day 3 was 11.4%, with a salvage rate of 40%. The number of flaps to stay in-house in order to salvage one flap during this time period was 907, which is associated with inpatient costs of just over $2 million. The incremental cost-effectiveness ratio here was $285,020. The percent of flaps that were taken back on post-op day 4 was 9.1%, with a salvage rate of 25%. They required a number of flaps to stay in-house. To salvage one flap was 1,813, associated with inpatient costs of $4.3 million and an incremental effectiveness ratio of just over 570,000. And then lastly, the percent of all flaps that were taken back after post-op day 4 was 9.1%, with a salvage rate of 0%. And due to the salvage rate of 0%, they were unable to quantify the cost numbers. So the authors conclude in their study that post-op day 2 would be the appropriate day of discharge for cost-effectiveness perspective of flap monitoring, balancing the likelihood of flap take-back and the likelihood of salvage and the associated quality-adjusted life years with a successful salvage. In addition to the article, there was 2 discussions that are published alongside. One is by Dr. David Song from Georgetown, and the other is by Dr. Evan Matros from MSK, which I think really nicely point out some of the limitations to the author's analysis and will be a good point for us to start our discussion. Dr. Song commended the authors for the attention to cost of care, especially in the setting of bundled payments, which may be on the horizon for microsurgical breast reconstruction. He recognized that the senior author has created a protocol at his institution for 23-hour discharges with rapid readmission protocols in place, and he also commended the low rates of take-back and high success rates on the take-back. However, this in combination with variable rates of costs at different institutions may make it difficult to generalize this data to other institutions. He also noted that the cost estimation was likely oversimplified, as specialized nursing may not be covered in the average inpatient stay, and that the oversimplified incremental cost-effectiveness ratio may subject the model to increased type 1 and 3 error. In Dr. Matros' discussion, he also highlighted some of the limitations of the author's cost-effective analysis, which the authors themselves describe in the paper to be a simplified analysis. He discussed that this should instead be considered a cost-utility analysis as opposed to a cost-effectiveness analysis, and pointed out that breast-Q data can't be used interchangeably with non-breast operations or medical treatment in a quality-adjusted life year calculation. Clinically, he noted that a successful salvage may not equate a successful breast flap that doesn't require a take-back, since the increased ischemia during the flap compromise period may increase the risk of flap necrosis and result in decreased quality of life. And then lastly, he highlighted that while the authors describe a cost-utility analysis from the perspective of society, what they performed was from the perspective of the institution. And a limitation to how they did this was from the perspective of the institution. Hospitals are often paid via Medicare severity diagnosis related group facility fee at a fixed amount that assumes an uncomplicated course. In the payment structure, the hospitals would determine the break-even point based on their institutional specific expenses of monitoring the patient, and then from there determine a break-even point at which they would lose money only at the rate of direct costs. And this represents a different structure of cost calculation than the average cost per inpatient stay that was presented in the study. That was sort of a long summary of the article and the different points that are brought up by some of the discussants, but overall, I selected this article since I thought it brought up a lot of really important discussion points related to post-operative monitoring of microsurgical breast reconstruction and post-operative care, including the general trend towards earlier discharges that are made possible by protocols such as ERAS. And Dr. Momoh, I just wanted to start with you and open the discussion up to you and hear what your thoughts were on the article.
I also enjoyed reading this article. And one reason is this is an area of my clinical practice and expertise. And I'm also very interested in ways to decrease cost and perform these big operations and patient care in a more efficient manner. I enjoyed reading this article. I'd like to congratulate the authors on putting forth an effort to look at this question and try to figure out from a cost standpoint, how long can we actually keep patients in the hospital? Is there really a benefit from the standpoint of our ability to salvage flaps with monitoring patients for extended periods of time? I think historically when we started doing a lot of these procedures, patients were kept in the hospital for 5 to 7 days and even longer, but gradually over time, especially with the post-operative pathways and ERAS protocols, we've gradually shortened the amount of time patients spend in the hospital after free tissue transfers for breast reconstruction. Now, looking specifically at this article, what I found to be interesting, and it's always an issue when we look at a single center study, the data and the patients are all from one institution, the University of Pennsylvania. They have a high volume of cases. They are experts in the field as far as microsurgical breast reconstruction goes. And so one would expect that their complication rates, their take-back rates, would be different from centers where surgeons don't have quite the experience. And so the question is, can these numbers that they used to calculate the cost effectiveness or the utility of keeping patients in the hospital be generalized to most centers across the nation? My thought is probably not. Now, the other question that comes up with this is how early is too early to discharge a patient? And based on what we're finding, is it possible that we just make a blanket statement and say, you know what, after a certain postoperative day, there's no reason to rush back to the operating room to try to salvage a flap. If a flap goes down after a certain postoperative day, should we just decide to call it quits and save society and save the hospital the cost of a lengthy operation in trying to salvage? So those are two questions that kind of came out in my mind as I read this. So where I'm going with this is, if all we're looking at are numbers and trying to figure out how can we save money, then the ideal day for discharge based on numbers would be much earlier, okay? Which at some level won't make sense, because the earlier you get, I mean, at some point you can get to post-op day 0 being the most cost-effective day for discharge. But then we're trying to take care of patients, and the question is, how would patients deal with this? Would this be the most ideal thing for patients, and would this be the best way to address patient care? And I think this is where clinical judgment has to play a role. I don't think we can make decisions on patient care just based on financial implications. I think we need to be good stewards of the limited resources that exist in our society. However, we also need to try to figure out what is best for our patients. So I think pushing the envelope and trying to get patients out almost immediately after they've undergone a lengthy operation, a lot of effort has been put into the reconstructive procedure. I just don't think it makes a lot of sense to force the issue to get patients out, let's just say, for example, on postoperative day number 1. I know this is something that's being looked at, but I'm kind of hesitant to say that this would be the best course of action for most patients. Now, with ERAS protocols, I think most people would be very comfortable getting patients out of the hospital practically on postoperative day number 3. In my practice, we've had a pathway. I called it a pathway, I guess, before the term ERAS was somewhat popularized, but it's essentially the same thing. And with the ERAS protocol, patients in general, most patients are able to leave the hospital about 3 days post-op. Now and then we have patients who are having a tough time either mobilizing or have concerns that could even be social concerns that make it reasonable for them to stay in the hospital an extra day or two. But in general, I would say most patients that stay longer in the hospital are not necessarily kept in the hospital for flap monitoring concerns. On average, with the protocol we use at the University of Michigan, our monitoring devices are actually taken off on postoperative day number 3 with the intentions of sending patients home. But for one reason or another, some patients stay a little longer.
That's really similar to our practice here at Duke. Our sort of ERAS protocol or pathway has patients set up to go home on day 3. And I haven't really encountered a scenario where we had a patient who was really wanting to go home on day 2 that seemed ready, and to see if that would be something, our attending staff would be comfortable with here, because then maybe you're starting to think more about flap monitoring. But again, it's not infrequent that we have a patient who needs an extra day in the hospital for, the reasons that you mentioned. And so personally, having taken care of these patients, obviously, you're someone who has a lot more experience than we do, but sending people home on day 1 would really take the right patient and a lot of preoperative counseling, I would think, and a lot of preoperative planning for that patient in order to move in that direction.
I think you make a very important point, as in many times the amount of time spent in the hospital is dependent on patient expectations. And so if a patient preoperatively understands that you send everyone home, for instance, on postoperative day 3, or let's just make it earlier, postoperative day 2, mentally they prepare themselves for that, and you set everything up in such a way that a higher percentage of your patients are ready to go home then. And so I found that to be very true. And then patients who come in expecting to be in the hospital for 4 to 5 days, they end up staying 4 to 5 days or find reasons why they're not ready to go home. And the other issue that I think is important when just looking at this from a larger perspective is the quality of care that we deliver is really assessed partly based on patient perceptions of the kind of care they've received. And many times in situations where a patient is doing well medically and they can easily go home, when you force the issue and they're not ready, one way or another, that leads to some level of dissatisfaction with the care they're receiving. And that is something that we can't completely ignore, since we are at some level also evaluated based on those factors.
Mm-hmm. Kyle and Raj, I'm curious your thoughts on what your experiences have been at your respective institutions and what your thoughts were on the article.
Thanks, Lily. This is Kyle here. You know, at UT, we've transitioned throughout my time here from more of like the 4 to 5 days to kind of a enhanced recovery pathway where, you know, post-op day 2, most of the patients are being discharged in that afternoon. Some of them have even gone home in the evening of post-op day 1 when they've had relatively uneventful free flaps and they're, you know, done before noon the day of their surgery, and they kind of just go through and they're ready to go and they don't want to be in the hospital. And then there's others that take a little longer, and not so much from the flap monitoring standpoint, but just from a getting them all the stuff they need to be able to feel comfortable going home. And I think, Dr. Momoh, you bring up a good point of this idea of patient perception, and it's one thing, and maybe it's more of a generalized question on healthcare in general, is do we want to talk about this idea of patient satisfaction in terms of it is in a lot of places tied to certain metrics and reimbursement, both from a physician standpoint in a hospital system wherein the department will affect bonus structures and payments, or even insurers will affect payments to the system based on how satisfied patients are with the care they received. And so I think it's easy, we could say from maybe an anatomic and physiologic standpoint that post-op day 1, we can send patients out, the flaps look great, but if patients feel like they're getting bumped out and they're not emotionally ready to go home, that's going to lead to a problem. The thing that really helped us with all of it, in addition to expediting the pathway, was just the preoperative assessment and just making sure patients understand what they're in for, what they're going to be like post-op day 0, day 1, day 2, that they're expected to typically go home on post-operative day 2. I mean, these are the things they do it. So they go into it with this understanding of what their recovery will be like, and I think it's helped significantly. And that kind of psychological component for a patient is almost more important than a lot of the stuff we can do clinically in that ARAS pathway.
Raj, what has your experience been like at WashU?
Very similar to what Kyle said and what Dr. Momoh mentioned, and you did as well, Lily. We've had an ERAS or Enhanced Recovery Protocol for a while now. We've written about it and published on it, and I still think we have some hesitation sending patients home before day 3. I think that would be kind of our mean and median is day 3, and what our target is. And in preoperative discussions, what we tell patients is usually 3 to 5 days. There are patients that have gone home on day 2 if things have gone just incredibly well. But I do think even with setting the preoperative expectations that patients are going to go home on day 2, as Dr. Momoh mentioned, it's not often that it's a flap monitoring reason that we're keeping patients longer than that. I think when you look at the patient comprehensively and you just don't look at cost as an isolated factor, I mean, there's a lot of other important factors that play a role into the care of the patient. You know, if you're going to send somebody home on day 1 or day 2, they need resources to take care of them at home as well, so it puts a burden on family members now. People have to take off work. I mean, so there's costs associated with that as well. So I think to just look at the cost, as this study did on what the generic cost of what a hospital stay in Pennsylvania is just not really the most accurate way of capturing costs from the societal perspective. So I do think that, as Dr. Momoh said, there's a balance between taking care of the patient comprehensively, being a steward of care, and also keeping cost effectiveness in mind. So personally, I wouldn't feel comfortable sending a patient home on day 1 definitely. I think day 2, in my experience, would be pushing it. And a lot of times patients, they're just psychologically not ready for that. They're worried about who's going to have to care for them at home. They're worried about a lot of different factors and just getting all the resources in place to take care of them. So we've done day 3, day 4 is typically what we average. And I don't think anybody's had really a problem with that. And the way the reimbursements work now, not to say that costs us everything, but you're really just not incentivized to send patients home on day 2, but you could be penalized if they're coming back. So I think what we really need to do is also look at studies that capture patient satisfaction, that capture perioperative pain control in the postoperative period, readmissions when you're sending patients home early. So I think those are all factors that would be important to look at. I don't know of the significant benefit between not monitoring. I think you can stop monitoring. We use the bioptics for monitoring our flaps, and typically we leave that on for 2 days, and then after that we just take it off. So we're not really monitoring flaps beyond the daily clinical exam after day 2 anyway.
Raj, I think you bring up some really great points, and I think, when thinking about kind of designing this ideal cost-based study, it's also important to think about what happens to these patients who do have flap failures. These patients who may have kind of been these partially salvaged flaps that may have more fat necrosis or may require a little additional volume or something, versus people who go on to have a different surgical reconstructive plan, and, what sort of the costs are associated with that. You and Dr. Momoh both mentioned at your institutions you guys stopped monitoring flaps, or at least start withdrawing some of the methods you use to monitor flaps at day 2 and day 3. Is that sort of an active decision based on we don't find in our hands that we're able to salvage flaps after this point? Or is that just sort of institutional dogma? Or how did you guys come up with those dates as cutoffs to when you stop monitoring flaps?
At Michigan, the protocol or the pathway we utilized was one that I introduced when I joined the faculty. I can't claim credit for it. I learned it from my mentors in fellowship training at Beth Israel Deaconess in Boston.
At Duke, I find that typically we will continue doing resident and nursing flap checks with some regularity, and unless we are short from a workflow perspective, the number of bioptics monitors or Doppler, implantable Doppler monitors we will just sort of reflexively monitor flaps until post-op day 5 if that patient was going to be in the hospital for other reasons. So this is often not breast flaps. This is often other types of flaps if these patients are having longer stays. But, if we had a breast flap stay an extra day or 2 for other reasons, I don't think we would routinely start withdrawing, their bioptics or decreasing the rate that residents are checking in on the flaps. So I was just curious about that at your institutions.
I think right from the onset, we try to stick with our plans for monitoring and decrease it gradually from day to day with Q-hour monitoring or evaluations by nursing staff on day 1 for the first 24 hours. We also use bioptics, so that's continuous monitoring for the full 3-day period, but the physical examinations by nursing staff and by our residents gradually decreases. The frequency of the evaluations decreases from Q1 hour to Q2 hours on day 2 to Q4 hours by day 3. The reality is the more you do this, the better you get at telling if a flap is going to do well. The reality is intraoperatively, when you perform a free tissue transfer, in most cases you can tell whether or not you're going to have problems post-operatively. There are always a few exceptions, but in general, when the case goes really well intraoperatively with the anastomosis, it's relatively rare that you're going to have a problem post-operatively, excluding things like maybe post-operative bleeding, for instance. And so I feel reliably when a flap is done well for 48 to 72 hours, the level of monitoring can decrease. And the reality is I really want to get patients home by post-operative day number 3. And once they go home, we're really not looking at those flaps the same way or with the same level of, scrutiny. And so I've essentially gotten comfortable with the idea of decreasing the amount of monitoring over the first 3 days. And by the end of day 3, I take away the bioptics specifically. But they're in-house, and so they'll be evaluated by nursing staff and by our team. Our team will evaluate the patients basically twice a day on rounds in the morning and in the evening, but definitely at a decreased level of intensity. And my thought on it is I would also like patients to start to feel like really we're not really doing much in the hospital anymore, and make them feel a little more comfortable about the idea of going home where no one else is looking at it but them.
I think with that, we'll end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune in to the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Momoh, for joining us.
Thank you.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.